Okay.
Thank you, Mark. Welcome to this session on tests of evacuation disorders. My name's Charles Knowles and I'm from London. I have Alison Malcolm, who's from the other side of the world, Australia. And we better get started because we're running late. So it's my great pleasure to welcome our first speaker, Dr. Mark Scott, who's going to give us an overview of the subject before the individual tests are considered. Thank you.
Indeed. Thank you, Charlie. Thank you very much indeed for Mark for the invitation and the organisation of this great meeting, and thank you for my chairs and friends. So, best test available for the assessment of evacuation disorders. So, I'm going to provide you with an unfiltered, deliberately provocative, hopefully thought-provoking overview of the test modalities that we have available to us. And then I'm going to pass over to our distinguished speakers who are around the room somewhere, hopefully to unravel the dilemma as to which test is best. And here are my disclosures. So the first controversy, because I think we'll all accept that this is the most controversial area of our diagnostic field. And I'll start with the first controversy. What is in a name? So we chose for this session to use the term evacuation disorder as the term to describe a patient's presenting difficulty with evacuation of stool. And the reason we chose this really it was first promoted by the authorship of a whole journal supplement devoted to chronic constipation, and myself and Satish were a couple of the authors on this. And it was further proposed to use the term evacuation disorder by members of the International Anal Rectal Physiology Working Group as part of the Nature Reviews set of documents on clinical measurement. Evacuation disorder, is this the term that is used consistently in the literature? Well, actually, if you look through literature, and I'm sure you all know it, that a myriad of terminologies are used. And many of these terms are used to describe what is believed to occur during spontaneous defecation, and many of these descriptors are used to describe what is perhaps measured within the laboratory, but they're used interchangeably, and this is one of the controversies and difficulties. So is it defecatory disorder, mixed defecatory disorders? Is it defecation disorder, abbreviated to DD, dysenergic defecation, abbreviated to DV, pelvic floor dyssynergia, pelvic outlet obstruction, functional outlet obstruction? I'll keep going, and these are all terms, if you go through the literature, that have been presented in the last, let's say, 5 years or so. Obstructive defecation syndrome, ODS. Obstructive defecatory symptoms, ODS. Functional defecation disorder, functional evacuation disorder, rectal evacuation disorder. What happens if you had surgery and you haven't got a rectum? So that doesn't quite work. Any others? Shout them out, please. Have I missed any? I mean, I can see smiles in the audience. It may be humorous, but guys, this is 20 descriptors that are used interchangeably. This doesn't help our field. But I think we can all agree that evacuation disorder as a term can be used as an umbrella term which covers, and again, I'm sure we can all agree on this, that there are so-called functional causes of an evacuation disorder which may be defined as abnormal rectoanal and perhaps Adil abdominopelvic coordination together with impaired evacuation. And there, of course, are structural disorders also that primarily reflect pelvic floor weakness leading to obstructive structural features such as large rectocele, high-grade interception, enterocele, etc., etc. So which tests do we have available to us in our diagnostic armamentarium? Well, we have so-called indirect tests. So these are tests that will measure variables deemed to be biologically relevant to the process of defecation. The first one of those is anal rectal manometry, and the second being transperineal or total pelvic floor ultrasound. Given that that is not included in this session, I'm not going to cover that in the remainder of the talk. We also have direct tests of evacuation. These are tests that employ evacuation of a stool surrogate. The simplest one, balloon expulsion testing. We have types of defecography. We have traditional X-ray defecography. As Satish said this morning, this is obsolete. Satish, it may well be in the US. It certainly isn't in Europe and the UK where we're from. MRI defecography, that of course is superseding to an extent traditional defecography. And we have the new kid on the block. Now, if you are of an age like me, when I hear the word fecobionics, it makes me think of Lee Majors. Does this make anything to you? Do you remember that, Shirley? The Bionic Man. But fecobionics, Hans, apologies for that. I'm, again, not going to concentrate on fecobionics at all. I'll leave that to you later in this session. I know you've got a session later on this afternoon also. What I'm going to cover is the best accepted tests. That's balloon expulsion, manometry, and defecography. But it's very important we have all of these tests, and therefore diagnosis may be test dependent. It's a very important take-home message and something that hopefully will come out more and more as I go through the talk. So let's start with another area of controversy. What do the guidelines say? So we have 6 tests, 6 that I've just described, available for the assessment of a patient with an evacuation disorder or symptoms of evacuation disorder. Let's start with the big hitters. This was New England Journal of Medicine, no less. Michael Camilleri and Tony Lembo, who say that the initial physiological tests to consider are anorectal manometry and balloon expulsion. Defecography may be considered if the results of these tests are equivocal, or if there's a clinical suspicion of a structural abnormality in the rectum that impedes defecation. I would argue that there's a clinical suspicion in any Paris female, but that's obviously for debate afterwards. The AGA medical position statement from 10 years ago, anorectal manometry and a rectal balloon expulsion should be performed in patients who fail to respond to laxatives. Defecography should not be performed before anorectal manometry and a rectal balloon expulsion test. Defecography should be considered when results of anorectal manometry and rectal balloon expulsion are inconclusive for defecatory disorders. Again, that terminology issue we've been talking about. But this at least promotes simple office-based tests. Rome, of course, focuses on so-called functional disorders, but does this clear up the idea of which test to use anymore? During repeated attempts to defecate, there must be features of impaired evacuation, as demonstrated by 2 of the following 3 tests. 3 tests, so that's surface EMG as well. So we've now got 7 tests that we're considering. The recent European Society of Neurogastroenterology and Motility Guidelines on constipation considers structural disorders more. There's a few statements in there, but the 2 that I'll highlight here, barium defecography is indicated in patients with refractory symptoms of evacuation disorder and can accurately delineate several rectal structural abnormalities that often coexist. And among commonly performed investigations for symptoms of evacuation disorder, barium defecography can be considered the gold standard for assessment of structural rectal abnormalities. So have these guidelines been at all clear for you, or is it as clear as mud? I have to say I've always liked this one. This is a paper that was led by Gregor Lindberg and the World Gastro Organization, who basically based the idea of testing modalities or the use of them on available resources. If you have limited resources, balloon expulsion test is cheap and simple. If you have medium resources, consider balloon expulsion test or defecography. And if you have extensive resources, you've got defecography, magnetic resonance proctography, or manometry that would be available to you. And I think that's a more pragmatic approach, perhaps. So the next thing I wanted to consider in terms of an area of controversy is test conditions. How acceptable is a test? Are they actually fit for purpose? And I don't want to go into detail on construct and content validity and reliability and what have you, but if we're considering a test for evacuation, surely for that clinical test to be valid, it should, to a certain extent, recreate the natural process. And of course, there's a huge caveat there that we're not looking at, or it'd be impossible to look at defecation through its whole process from, obviously, brain downwards. We're looking at the final act. However, I'll raise a number of conditions relevant to the test environment that I would argue are controversial in terms of whether this is truly an acceptable test. So, as I've said, I will consider the 4 most widely used and established tests in this next few slides. So let's pose a few questions and see if the tests meet these conditions. So, first question, does the test measure evacuation? So we're talking about an evacuation disorder. Surely that's one of the basics that we should try to evaluate. Look at anorectal manometry. This does not. It is de facto not a test of evacuation. You are not evacuating anything from the rectum, but the other three tests do. Does the patient assume a normal posture? Again, if you look at manometry, how it's traditionally performed, and of course I'm cherry-picking a little bit here, but generally it's performed in the left lateral position, therefore clearly it is not a normal defecatory posture. And MRI defecography in almost all cases is performed with the patient lying supine, and I suspect I don't have to ask anyone in this audience whether any of them traditionally go to the toilet lying on their back. So clearly that's an abnormal defecatory posture as well, and there are differences between the defecography techniques that are put down to posture. At least balloon expulsion and traditional X-ray defecography are in the seated position. What about stool consistency if we're assessing evacuation? Is stool substitute a normal consistency? Again, we can base this on the Bristol stool scale, which you all will know. Manometry doesn't involve expulsion of anything, so we'll cross that out again. Balloon expulsion test. Sorry, let me pop back up. The balloon expulsion test. The balloon is probably around about type 3 to type 4 on the Bristol stool scale. Barium paste, a little bit looser, probably types 4 to 5. MRI gel is somewhere down at the bottom end of the scale. Again, I'm just raising these as concerns about test conditions. Does the patient have sensory awareness of the urge to defecate? And we all know that intact and integrated sensory processes are absolutely fundamental to normal defecation. But what we also know is in the index group that we're looking at, those patients with evacuation disorder, 25% of constipated patients have impaired rectal sensation. They have hyposensitivity. And I would argue to you that the ideal test, we should be providing a sensory stimulus, as we normally have in defecation, that provides some cortical awareness of rectal fullness. So again, this isn't something that is covered by manometry. Balloon expulsion, the balloon is usually inflated to 50 mils. If in hyposensate patients, the likelihood is they simply wouldn't feel this, so there'd be no sensory input to the process. MRI defecography is a larger volume of gel, but again is unfelt in a proportion of patients. Same thing with barium defecography, although many centers individualize the volume that goes into the rectum, so perhaps this is the closest to providing that sensory awareness. Is evacuation studied for an appropriate time? We've just done a big survey, Charlie and I, in the UK, of UK bowel habits. It came out that the average time that a member of the general population spends on the toilet is 4 minutes. So anorectal manometry is usually assessed by the push maneuver. The push maneuver, maximum perhaps 15, 20 seconds. This, according to what normal population says, is a very truncated time. The other tests all record the event for the duration of its happening. And just to balance things a little bit, does the test avoid irradiation of the patient? Clearly, with barium defecography, no, it's not avoided, but with the other three tests it is. So I've picked a whole variety of different areas there, but just showing you, again, some controversies that absolutely exist. But perhaps the biggest area that we should look to compare the test is which diagnoses or what diagnoses are actually possible with the tests that we have, and again considering either functional or structural diagnoses. The first thing is, can we determine impaired evacuation, so actually parameters of evacuation that are outside of normal, so either delayed or taking longer than normal? Again, anorectal manometry, no, it doesn't provide a measure of impaired evacuation, but the other three tests certainly do. What about assessing functional disorders? The balloon expulsion test looks for impaired evacuation on the basis of time. That's it. That's what it tells you as a test. Manometry can look for patterns of abnormal rectoanal coordination, and both barium and magnetic resonance defecography, you can actually image any abnormal musculature movements. What about structural evacuation disorders? You know the answer to this. Manometry can't, balloon expulsion can't, but defecography can. So again, this goes back to the idea that diagnosis may be absolutely test-dependent. And to provide our definitive diagnoses, are the diagnostic cutoffs clearly defined? So again, I've cherry-picked this a little bit, but it just wants to raise that idea that we haven't got everything in our minds straight. So is it 5 minutes? Is it 3 minutes? Is it 2 minutes? Is it 1 minute? Is it, as the Mayo said very recently, 22 seconds? What is the upper limit of normal? We haven't consensus on that. And although, as I said, I try to provide a relatively objective view of this, and as you probably all know, we use defecography in our practice, but of course, one of the biggest considerations always thrown at defecography as a criticism is, are anatomical abnormalities, in inverted commas, truly pathological, or are they a normal variant? We studied this at the London, and we found that 26 of 28 healthy volunteers who went through this procedure to provide for our normal ranges had a rectocele less than 4 centimetres in size. So it is a normal variant. The vast majority of women have one. Adil's published the same sort of data. 70 of 113 healthy volunteers who went through MRI defecography had a rectocele greater than 2.5 centimetres in size. So again, something hugely to bear in mind and does absolutely impact our ability to diagnose. And to extend beyond that, I'll just pick on manometry when we're looking at discriminatory ability. So I'm sure you're all aware of this study. This made some waves when it was published a few years ago, where we did a diagnostic accuracy study of manometry in relation to try and diagnose dyssynergia. 170 subjects, 85 of whom were healthy volunteers, 85 of whom were patients with symptoms of evacuation disorder. And 3 of us on that authorship analysed the push manoeuvre looking for dyssynergic patterns, and we were all absolutely blinded to the subject status. We had no idea whether it was a patient or a volunteer. Lots and lots of numbers here, but the take-home messages are these. 94% of patients had an abnormal pattern of rectoanal coordination. Great test, you say, fantastic. 87% of healthy volunteers did too. Absolutely no discriminatory ability. And in fact, type 1 dyssynergia was more common in health, significantly so, than it was in patients. So high sensitivity, very, very low specificity of the test, and it was only type 4 dyssynergia that is characterized by poor rectal propulsion that was modestly useful for discriminating patients from volunteers. And the final sort of controversy I'll raise, literally, I'll be about a minute here, Charlie, if that's okay, is their test result agreement. So here's a typical patient, 61-year-old female at our institution, 4-year history, lots of symptoms, very much typical of those with an evacuation disorder. So protracted defecation, lots of straining, feel of incomplete emptying, resorting to digitation, etc., etc. When we did the tests, manometry showed very, very clear dyssynergia. However, balloon expulsion test, she expelled the balloon within 17 seconds, absolutely normal, no impaired evacuation at all. When we did defecography on this lady, this is real time, this takes around about 25 seconds. So you can see the anal canal opening there, there's pretty rapid, and you'll see ultimately near complete evacuation. But what you will see developing here is a very, very striking, I hope it's projecting well, but a very striking high-grade intussusception, so a rectoanal intussusception. So normal evacuation, high-grade intussusception. The question is, which is right? Which is the correct diagnosis here? And what's important, I think, from that slide is that patients can have an evacuation disorder, but they may not have impaired evacuation, so delayed or incomplete expulsion of rectal contrast. So highly symptomatic patients may have entirely normal parameters of evacuation, so they can't necessarily be discarded at that point as having no evacuation dysfunction. And really the final slide is their test result agreement. So the final controversy, and I think again we know the answer to that. This was a paper we published about 7 or 8 years ago now, 100 consecutive patients with symptoms of evacuation disorder. Adil was involved in this paper too, where we looked at the agreement between the 3 index tests of evacuation, balloon expulsion, manometry, and barium defecography using kappa statistic. As you know, with a kappa statistic, if you have perfect agreement, you have a rate of 1. But the agreement between balloon expulsion, barium defecography was only fair. Between manometry and defecography was slight, and there was no agreement whatsoever between the other two tests. This has been reproduced by some but not others. I know Adil's just produced a paper very recently that shows better agreement, at least with regard to impaired evacuation. But to quickly summarize, we're in a bit of a mess. And you know, I'm the first to say I'd love to be able to solve and unravel this mess, but we have very variable terminology used to describe the condition. We have 6 or perhaps 7 available tests. Use is somewhat dictated by resources, but there is no clear gold standard. We have inconsistent guidelines. We have questionable test conditions. We have often poorly defined diagnostic cutoffs and poor test agreement. And ultimately, this impacts credibility, certainly peer acceptance, and it ultimately impacts patient management. So we talked about the International Anorectal Physiology Working Group, London 2. That's the sort of process by which hopefully we can resolve these issues. Thank you, guys.
Thank you. I'm sure there are lots of questions, but in the interest of time, I just want to thank you, Mark, for setting the scene perfectly for the controversy that I suspect will follow. I think all the talks coming are deserving of the exclamation marks that Mark has given them after their title. And the first, we will have Henriette Heinrich from Basel, Switzerland, who will perhaps convince us that the best test is manometry.
Will I? So I'm just waiting for my talk to open. Thank you for the kind introduction. And I also would like to thank Mark Fox for giving me this wonderful topic, defending manometry as it being the best available test for evacuation disorders. I'm just going to put a question mark there for my own sanity. What is manometry? Manometry is basically a stick with pressure sensors that we can put into orifices, right? When you look at the Wikipedia definition, it's esophageal manometry, anorectal manometry, and rhinomanometry. Interesting. But anorectal manometry comes second. The history of anorectal manometry is intriguing. In the beginning, as it is now, it was a pressure sensor combined with different balloons in a kind of complex construction to measure the relaxation of the anorectal sphincter. There were weights attached to it, and it looks like a very, very tedious procedure. You can also see, historically already, it was performed in a left lateral position. We have come a long way. You all know these images, these pressure plots where high pressure is red and lower pressure is blue. The catheter is put across the anal sphincter and produces this nice image of a contracting muscle. And what do we actually like about manometry? Well, we always use it. Everyone uses it. We love it. It's the best established and the most frequently used test for the assessment of anorectal function. But as Mark Scott has already told us, it's actually an imperfect tool that doesn't tell us anything. And I think that's quite unfair. I'm going to try to give a little bit of a positive spin to anorectal manometry, which is actually a tool that we love to use, but we also love to debate about it and we love to hate it. So if you look at it, we've been talking about high-resolution anorectal manometry more and more across the last years. It started off in 2007, little peak around 2014, then what I call the London effect around 2018 to 22. This has really peaked. In 2023, we haven't been doing so well. But what you can see from this graph, the interest has grown in this imperfect tool, and there are more and more data coming out that might actually make this tool not only nice to use for the clinician, but also usable. So let's talk about the negative things a little bit. What are the pitfalls of the technology? Lots of people will bang on about the equipment, about the normal values. The investigator will influence the results. Is it reproducible? It cannot distinguish between health and disease. And as Adil Bharucha has asked is it just an expensive hobby? I'm going to try to unravel this a little bit. When we look at equipment, we have to be aware that there are 1,000 kits on the market. They all have different sensor designs and different sensor spacing. They collect data differently, and therefore they produce different pressures when you put them, for example, in a pressure chamber. Here you see 4 different catheters put in a pressure chamber. Black is the perfect pressure that they should produce, but if you actually put certain pressures on them, they produce vastly different values. That is not because the catheter design is bad, it's because the sensor density is different. And this is the reason why you always need your normal values for your specific catheter. Also, you need to take age, parity, and gender into account. Normal values, have we progressed in that regard? I would say yes. There was one set of normal values 8 years ago. Now there's 4 to 5. And there's also now the awareness that gender plays a role. So we're kind of moving there. What about operator bias? Well, my first study on anorectal manometry concentrated on the fact that if you told people to squeeze very hard, they would squeeze harder. I proved that. I'm still very proud of it. And these results have also been reproduced by Dr. Pritchard. And he also showed that if he looked at 6 nurses and the data of the anorectal manometries they performed, there was significant variances if you looked at the values that they produced. So the operator, also if they use the same instructions, have a massive impact on the results. And I think one of the key novelties is that there's now kind of an agreement on how to motivate and how to interact with the patient. But still, although these nurses gave the same instructions, the values varied greatly. What about reproducibility? Well, there was a study recently in 2022 which looked at the reproducibility of high-resolution manometry among healthy and constipated persons. They were reproducible in health and disease, but the outcomes, when they were looked at on different days, differed in 79% of constipated patients. So that's not really good. So that's probably the study that killed my anorectal manometry buzz for a very long time. Mark has already talked about it, which basically showed that the pattern of dysynergic defecation isn't really useful in distinguishing health from disease. And I was really sad about that because my second study was exactly about that topic, that anorectal manometry, when compared to MRI defecography, wasn't actually that bad in detecting dysynergic defecation. So I was really surprised by these results, but then I realized Mark's probably right, because also in an MRI, people are lying on their back. And having talked to my study subject who had to evacuate lying on their back in an MRI, I can also understand that MRI causes dysynergic defecation. But now this study kind of puts it all together again. Adil Bharucha study from 2022. It's the pre-final verdict, and it puts an oldie but a goodie in the spotlight, the rectoanal gradient. If it is negative, it has a very good predictive value in saying that you probably have dysynergic defecation. If the balloon expulsion test, in addition, is pathologic, the probability of you actually having a defecatory disorder is very high. So this elegant study shows us that there is a value that we can produce with anorectal manometry that tells us something about the pathology of the patient. Also, it can distinguish between health and disease. So we're moving into the right direction. There's also data fresh from the DDW, a study of 384 patients answering a questionnaire and undergoing high-resolution anorectal manometry. And this study compared conventional measures of anorectal manometry with the measures proposed in the London classification. for predicting symptom severity in fecal incontinence and constipation. And for constipation, the London classification performed really, really well in predicting the severity of constipation. Conventional measures also performed well, but here the London classification with regards to abnormal propulsion really did the trick. So what about the variability in clinical practice? This is a study by Alison Malcolm, which I particularly love. It shows that we all do what we know. Gastroenterologists send constipated patients for anorectal physiology testing, for anorectal manometry. Surgeons do imaging. And I think that is the basis of where our discussion should start. And we all know this data from Emma Carrington, where she did the questionnaire on how we performed anorectal manometry a couple of years ago. It was all over the place. No one actually adhered to any guidance, lots of different numbers of maneuvers performed. And I think the follow-up questionnaire that will hopefully come will show us that we've also now found agreement and that we have a more homogeneous practice that will help us compare results and treat our patients better. And to come back to Adil, who said, maybe anorectal manometry is just an expensive hobby. No, as he said, it's worth every penny. This is also data from the DDW, which actually shows that from a insurance perspective and as well from a patient perspective, you save a lot of money by investigating your patients who have failed OTC treatments with anorectal function testing. From a patient perspective, sending your patients for anorectal manometry saves you almost $10,000. So I guess we can say it's worth every penny. And in summary, and to lead on to my next speaker, Giuseppe, who's going to talk about the balloon expulsion test, I put this red little balloon. And with equipment and normal values, we are getting there. We're moving into the right direction. Reduced ability to distinguish between health and disease, we're getting there. Is it an expensive hobby? I think we can say it's worth every penny, also because we really like to do anorectal manometry. And with regards to investigator dependency and reproducibility, we need to do a little bit of more work. Thank you for your attention.
So in the interest of time, we're going to move straight on, and it's my great pleasure to introduce another friend and colleague, Giuseppe Chiarioni from Verona in Italy, who is now going to, well, you've been introduced with the red balloon. Tell us about balloons.
Let me see. Can you help me, please?
Yeah.
Thank you. I start saying that I have to thank Mark for giving this privilege of being there with you and, you know, to have the chance to meet such a number of great friends of mine and telling you that still, you know, think about the great masterclass on constipation in London. And some of the slides you will see are coming from a presentation of Professor Knowles, taken directly from that place. Okay, thank you very much. So I changed the title. I like this one a little bit better. So anyway, this is my coil. Test of evacuation, which is the gold standard, short answer, none. That was his first slide, and I love it. And so after this slide, then see what we can do. So the ideal evacuation test, quick, minimal invasive, and cheap. Avoid arms, including radiation, perform in normal, or likely normal sitting position, performed in private, mimics stool consistency, provide distinction between healthy and patients, diagnose pathology relevant to symptoms, and inform and influence management. Which one is best? We have already been told about direct and indirect testing, and thank you, Mark, so we can just skip this. We have always to keep in mind that defecation is a multi-dependent process. You know, for example, you told us that the intact neuro bowel ways are relevant, and are definitely relevant, but with massage, for example, and adequate posture, you know, even paralyzed people can empty their bowel. They are grazed by the fact that they don't feel stool, so they cannot tell you if they evacuate completely the rectum, and that's the difference, but evacuation can happen. So this is an Adil Bharucha slides. We have also to deal with functional defecation disorder and to structural alteration of the pelvis. And that's a major issue. And this is the ghost eater to the table of constipation. Fecal consistency. We don't address it thoroughly, never. But it's main driven of symptom. Why we know this? Because if you look at the conservative care in randomized controlled trial of biofeedback in this synergification, you will see that in some randomized controlled trial, inadequate care could heal the symptoms, even in 40–45% of people, just, tailoring laxatives and tailoring posture, and that's it. So this has been already shown, and you will see that my balloon, it's more similar to type 1 and type 2, because my point, the point of my whole career, is to cutting out the waiting list for biofeedback. I don't need to do any more biofeedback patient, 1,000 patients waiting out. And so what I want, if you are able to taking out my balloon, you can't have an evacuation disorder. This is it. And so, God, I'm a sinner. Believe me, the producer will tell you that this is a folly, a 16 French folly. The producer will tell you that you are going to hell if you are going to blowing up more than 30 millimeter. But I am blowing up at 50, never saw a problem. And when I talk with the surgeon, they use it. They use it in the abdomen. And the surgeon told me, who cares about the inflation? We inflate at 80, 100, nothing happened in the abdomen. What happened in the bowel? Nothing. It never happened. This is a slide from Mark. Privacy, that's wonderful. We need privacy. I'm not going to stool in the front of a physician or a nurse. So that's what we developed. At the very beginning, we start concentrating on failed balloon expulsion tests. And we gave this 5 minutes. But the patient got exhausted, and she didn't want to repeat anymore. So we start concentrating about delayed balloon expulsion tests, and we decided to use these 2 minutes because we have data on this. I can tell you from relevant research about the group of Alison Marco and Yov Mador, that is a great guy, that would tell you that it's likely age-dependent, this time. So this is the trial that has been already quoted. I can tell you for sure, the balloon expulsion tests do not distinguish between functional defecation disorder and structural defecation disorder. There is no way to distinguish. And the major limitation of this trial is that defecography was performed only in patients where the balloon expulsion test and rectal manometry were discordant. But I can tell you for sure, balloon expulsion tests cannot distinguish between structural and functional alterations. Not going on? Yeah. So here, this is the validation. You see excellent reproducibility in my hands. And it's, it's great. You need to have a test that is reproducible. Another thing that your nurse will care about, no learning curve. Cheap test, you can have something like my clinic, €1, you pay €1 for a box of 20 catheter. So nothing. The nurse will love it. There is no learning curve at all. It's simple, accessible, very easy, and it's reproducible. So you can use it for research. And the new test, the new balloon test that has been developed by Bill Chase group, it's very similar to my balloon. They are kind of, in my opinion, they are trying to, they're trying to do this normal interval. If it's too low, it's not good. If it's too high, it's not good. The time the time of straining. I mean, what are we looking for? Athletes? Are we looking for Jacobs? I don't know. No idea. I mean, and this is the great study of Alison Malcolm group, where I have the privilege of reviewing it. I had it accepted. I love it. I love it. So let's say one thing. Foley, they compare Foley, party balloon, and commercial. The Foley took longer to expel compared to diverse balloon. 10 healthy volunteers could not evacuate Foley, and many find it uncomfortable. The study favors balloon among non-latex beds. Attention, approximately half of Foley failures show low, question mark, because we really don't know what is low with high resolution manometry, rectal straining pressure. So at the end of the day, my conclusion is hard stools might be complicated to evacuate even for a healthy volunteer. So if you are in more than 50, you might find difficult to expel the Foley catheter. But again, if you expel the Foley catheter, you are out of my biofeedback list. And this is most important for me. So this is my old study where we show that a functional defecation disorder can delay the colon transit through all the bowel. And we show that the result of biofeedback influenced outcome. We were first showing it. Here we had still the old condom-style balloon that we were measuring failing. And, effects of biofeedback on transit time, effect of biofeedback on balloon expulsion test, it did improve it. But particularly, feature of dysynergia at low resolution manometry and or BET at baseline predicts outcome in a 6-month follow-up. So now we have a test that can help us to distinguish the patient that will benefit from biofeedback. And it has been confirmed. This is our following trial. And, again, the same trial. This is Satish Rao trial. We are all going this way. Dysynergia in low resolution or rectal manometry and BET do predict the outcome of biofeedback. And this led to this guidelines constipation that has been chaired by Jordi Serra and Daniel Paul to tell that, yes, biofeedback is indicated for these people. Balloon expulsion test can predict the outcome of biofeedback even when constipation is not the main symptom. These were levator ani symptom, again, an old study. Levator ani symptom was dysynergia that could not expel the balloon, and biofeedback could predict the outcome of the pain. So improving the evacuation disorder, even if you are not constipated, would result in an improvement of the pain. I'm not so idiosyncratic to quote only my positive study. So this is, again, a study from Bill Che group. No, it's probably not Bill. Anyway, it is correct. Anyway, so what they are telling us, this is not a referral clinic. This is general. And they are general constipation people. And this reminds me of an old CAM study. So if you try to apply the result of that to the general constipation people, would not be effective on predicting the outcome of biofeedback, because it's the same thing that biofeedback for fecal incontinence. If you apply biofeedback to all the fecal incontinent patients, would not be more effective than diet advice. And it's the same thing. If you apply biofeedback to all general constipation, then you would have a 50% improvement because it's, the attention, the using of posture, of abdominal straining, all this. It's behavioral training, like they do in the UK. So that would not predict the outcome. But this is a different study. Again, from the BCHE. No, it was not. It was not BCHE. It was another group. No, maybe it was BCHE. Anyway, this is the referral. Here, they have people they were not able to expel the balloon, and changing the posture with the footstool, it did improve the outcome. And it did improve, the symptom and the expulsion of the balloon. So at the end of the day, keep calm and be positive, because at my outlet dysfunction clinic, rule 1, bed tender is always right. And rule 2, any doubt, rule 1 applies. Thank you for your attention. Sorry, just to give you a laugh. This was your last slide, but I changed it a little bit.
Yeah.
Shall we just move on? And then
Yep.
perhaps have
Questions at the end?
Yep.
Yeah.
Did I run out of time?
No, you
No,
didn't.
you're perfect.
fine. We're catching up.
I think our next speaker certainly needs no introduction. We're now going to see whether defecography perhaps is the best test. Dr. Adil Bharucha from Rochester, Minnesota.
Adil, as you can see, has had so many talks, he now knows my system.
That's right.
Good. You sometimes need to click twice for completely uncertain reasons.
Thank you very much, Mark, for really organizing this so thoughtfully, to Mark Scott for setting the stage, for Henriette for your very candid and balanced presentation, and Giuseppe, of course, is Giuseppe. What can I say? So these are my disclosures. And so I'd like to make 4 key points during this talk. First is that in most patients done appropriately, the results of anorectal manometry, the rectal balloon expulsion test, and defecography agree, provided the tests are interpreted relative to appropriate normal values. And the selection of tests is really guided by the indication availability and price. And there are pros and cons to all of these tests. There are 2 key indications for defecography, as Mark Scott pointed out, when the results of the manometry and balloon expulsion time are inconclusive, or when you suspect pelvic organ prolapse, especially when surgery is being considered. That said, Mark has ready access to defecography, so he has access to the test, and all power to him for using it as a first-line test in his practice. The prevalence of abnormalities in a clinical practice depends on the population being studied. In the patients that I see, most of whom who have not had prior surgery, the prevalence of structural abnormalities is relatively low. In Charlie Knowles' practice, I suspect it's much higher. And abnormal findings, as I'll show you today, at least in our hands, seldom impair rectal evacuation. And then I'll briefly cover the pros and cons of barium versus MR defecography, and then end on a high note, hopefully, with manodefecography. So just to go over, in most patients in our practice, the manometry and balloon expulsion time suffice to either exclude or confirm the diagnosis of a defecatory disorder, and the defecography used only in selected patients when there's a discrepancy or when we suspect pelvic organ prolapse. A point to emphasize is that more than 90% of patients with a large rectocele or an enterocele or a peritoneocele or a sigmoidoscele have a normal balloon expulsion time, simply because the pelvic floor tends to descend in such patients. So obviously you recognize that with your clinical exam, but that's the one setting where defecography is particularly helpful. The defecography shows several flavors in patients with defecatory disorders. There's this one patient here, you can see she's trying, but she has inadequate perineal descent. Obviously, I didn't need an MR to diagnose that and was unable to expel the gel. The patient in center, you'll see that the anal canal opens, but despite that, she doesn't expel the gel, arguably because she didn't generate a sufficient pushing force. And this third patient will ultimately evacuate, but evacuate at a price because she has marked perineal descent, she has a large rectocele, and a cystocele, presumably because she's been straining for decades in an attempt to evacuate. Other patients shown here, and these are the types of patients that our surgical colleagues see, will have, you can see the prolapse here, the enterocele, and a peritoneocele. And I show this more as show and tell because some of these patients actually have thickening of the internal anal sphincter. Yet other patients, this is actually a rare example in my hands. She had an enterocele, And the enteroceal obviously impaired rectal emptying because she had residual contrast in the rectum even after she was excused to go to the toilet. So what is the prevalence of structural abnormalities? In this tour de force by Hugo Grossi, Charlie Knowles, and Mark Scott, over 800 patients, 80% were women. They defined functional abnormalities by the criteria listed on this slide. And to cut a long story short, in 1 of 6, the exam was normal. 1 of 5 had a functional abnormality. Some of these patients also had structural abnormalities, clinically significant or not. The totals exceed 100% because some patients had more than one abnormality. We evaluated the relationship between structural abnormalities and rectal evacuation. To avoid bias, we use this program to not only measure the landmarks, but also the rectal area. And so Dr. J.G. Fletcher assessed for the structural abnormalities. A separate person marked the rectum and assessed evacuation. And so this slide just compares barium and MR defecography. So amongst people who had a rectocele more than 1 centimeter, you can see that the rectal evacuation was comparable with barium, but with MR defecography, the ones that had the rectocele emptied more. Complete emptying of a rectocele. So when the rectocele emptied completely, patients with barium defecography emptied more. Doesn't surprise you. This looks at the relationship between rectal intussusception and evacuation. And as you can see right there, with MR defecography, the patients who had intussusception showed here actually emptied more than the ones that didn't have the intussusception, presumably because they were straining more. With enteroceles too, enteroceles were associated with more rectal evacuation. So just to cut a long story short, this suggests that at least in our practice, rectal evacuation is unlikely to be explained in most patients by structural abnormalities. You all recognize that most proctography reports, maybe some of you have access to radiologists who, if you will, differ from this. Most proctography reports I read don't include measurements and don't compare findings to normal values. Indeed, normal values for barium proctography are relatively scarce, and one has to just bear in mind that the rectoanal angle may not increase during defecation, even in healthy people. So as you can see, for barium defecography, normal values in a total of 51 healthy women. Mark, maybe you have more. Are normal values for MR defecography in 113 women. All the values from the original Shore study, they were nulliparous women. They filled a variable amount of contrast in the rectum. The angle at rest was roughly 100. When they squeezed, the angle declined from an average between 15 to 30 degrees. On the other hand, during defecation, the angle increased by 20 degrees in both these studies, but only by 4 degrees in the study by Shore. That shows the number for descent. If you look at intussusception, we found 10% of healthy people. Mark, you had 18%. This original paper by Shore, 43%, and that too in nulliparous women. I find that a little hard. As Mark pointed out, rectoceles are relatively common. Enteroceles are extremely common, at least with MR. In these two studies, the small intestine was not opacified. So my practical definition for clinically significant abnormalities is for barium is when patients evacuate less than 50%, when the perineum descends by less than 2 centimeters, and when there are substantial structural abnormalities as listed right here. By contrast to barium defecography, MR doesn't include radiation exposure. It's performed in the supine position, which is probably why even healthy people, the lower limit of rectal evacuation is 20%. It offers much better spatial resolution, which is why you can assess for anterior mid-compartment prolapse. And if you use an endoanal coil, you can also look at the sphincters. There's some angst that, as Mark pointed out, because several earlier studies, for example, this one by Liliana Modiano, and Mark, you quoted the study by Pallet, suggested that there was limited agreement between the various tests of anorectal function. So in this cohort of 120 patients who had defecography, roughly 50% had dyssynergia, and amongst these 50% of patients, you can see that the results of EMG and the rectal balloon expulsion test were really the flip of a coin. And so you ask yourself, what indeed did these patients have? The normal balloon expulsion test and dyssynergia, did they have dyssynergia or were they normal? And we see this every time, right? So I just show this example of this 38-year-old lady, lifelong constipation, typical symptoms, unfortunately had all these risk factors. On the rectal exam, she had a narrow canal, a hesitant squeeze, no descent tender puborectalis. During evacuation, you can see here, Henriette, a slight increase in pressures, no rectal pressure, prolonged balloon expulsion time. But Mamma Mia, Giuseppe, she evacuated all the barium, right, during defecography. Okay?
Consistency, that's the main point.
Your point's well taken, thank you. And so the results of the test depend on the position, the amount of rectal filling, and the perception of the desire to defecate. So is one test wrong, the other not? Of course not, because defecation is a somatovisceral process with a volitional component. And even NBA, these are the top league NBA players, missed 18% of free throws. 18% is like a slam dunk, okay? So you've heard about this study so often that you'll probably get sick hearing about it again, but I'm just going to make a few key points. That is that whichever anorectal variable that you use, when you compare it to incomplete evacuation, the specificity is very high. We focused on the gradient because that was the most sensitive of all the variables that you can see right here. Then the question becomes, well, what about 1 versus 2 abnormality? And, Henriette showed this slide. You can see if both are normal, you're probably home free. If both are abnormal, you're home free. If only one's abnormal, you probably have approximately a 50% chance of having impaired evacuation. The third question becomes, well, does the rectoanal gradient add to the utility of a prolonged balloon expulsion time? And this analysis, you can see that if your balloon expulsion time was prolonged, you have a 4-fold increase of having impaired evacuation. And even after adjusting for a prolonged balloon expulsion time, the gradient actually added and was incrementally useful. Was the agreement within the balloon expulsion time and evacuation on defecography? In this cohort, you can see a third had a prolonged time, 2/3 had a normal balloon expulsion time, and the patients with the normal balloon expulsion time, only 1 in 5 had reduced evacuation. If the balloon expulsion time was prolonged, 58% had reduced evacuation. And so this is a question of cup half empty versus half full. I'm a half full type of person. I say, okay, this is 19% versus 58%, the cup half empty. People will say, well, even in this group, 81, these 19% you would have missed. Mark would say if you only did the balloon expulsion time and you didn't do defecating proctography. Okay? This part is a little interesting. So you can derive an equation for predicting the risk of someone having a prolonged balloon expulsion time from anorectal manometry. Okay, forget about the details. So we had these constipated patients who had defecography and a balloon expulsion time, and based on the numbers, 135 had a probability of an abnormal balloon expulsion time of less than 60%, 19 had a probability of greater than 60%, and you can see if the manometry said that your odds are higher, they were more likely to have reduced evacuation. If the manometry said you had a lower probability, only 25% had reduced evacuation. So now comes this question, okay, which would interest Giuseppe in particular. So these are the patients who had a normal balloon expulsion time. And in these patients with the normal balloon expulsion time, based on the manometry parameters, the manometry said, yes, your probability of having an abnormal balloon expulsion time is less than 60%. But in 6, it says, no, even though your balloon expulsion time was normal, you have a high risk of having a prolonged balloon expulsion time. And in fact, when we looked at this with defecography, 2/3 of patients in this group had reduced evacuation versus only 16% in that group. So to finish off with manodefecography, by no means am I suggesting that everyone needs to be doing manodefecography in clinical practice. This is research sort of advancing. Thank you. So for the first time now, we can, potentially kill two birds with one stone and better understand the mechanisms of impaired evacuation. So two clips I'm going to walk through. One is an evacuator, another is an evacuator. And when I press the start button, you look both at the images here and you look at the line as it moves through the tracing. Here goes. So you can see in this evacuator, notice how there's an increase in the rectal pressure first event, the perineal descent. As it's going through, the canal opens and there's complete evacuation of the rectal contrast. Okay? By contrast, in this non-evacuator, you can see, I'm going to clue you in, the increase in rectal pressure only shown in green compared to red right here. And you can see that she's clearly trying to evacuate this perineal descent, but she just doesn't generate an adequate propulsive force sufficient to overcome the anal resistance right there at the bottom. And the other advantage of doing manodefecography, if you do it with MRI, is that you can simultaneously assess the expansion of the abdominal wall. So you can see in this evacuator, notice that the rectal pressure increases, but that the anal pressure also increases at the outset of evacuation. Ultimately, the rectal pressure approximates and exceeds anal pressure, generating the gradient necessary for evacuation. By contrast, in this non-evacuator, the rectal pressure increases, but doesn't quite reach the level of the anal pressure. The gradient is negative, evacuation doesn't occur. Through the maximum anal diameter and the maximum rectal pressure, you can predict the odds of being an evacuator or not and identify clusters amongst these patients. So again, for most of us who don't want to use defecography day in and day out, two key indications. Barium proctography visualizes anorectal and pelvic floor motion and rectal evacuation. MRI has better spatial resolution for the anterior and middle compartments. Manodefecography may provide novel insights. You have to, like with all these tests, interpret these findings relative to normal values because healthy persons may have abnormal findings, and these are the limitations right here. Thank you very much.
Thank you, Adil. Again, in the interest of time, we'll move straight on. We may have some discussion at the end, depending on the timetable. And our final speaker is Hans Gregersen. Where is Hans? He is there. Yes, there he is, coming up. Hans, you know in San Diego, you've moved again.
I moved again, yeah.
Okay. Okay. Well, it's great to...
It's better than in London.
Yes, yeah, it certainly is, especially at the moment. So Hans is going to tell us about some new technology which may or may not make all the other discussions redundant, but he'll let us know.
Thanks a lot. And thanks to Mark Fox for being so open to technology, to Mark Scott for kind of pointing out the controversies, and for the three previous speakers for talking in favor of their technologies. As you can see from the title here, I'm going to take a different standpoint. It's none of the above or before mentioned technologies, but maybe we can take some good elements from them and kind of twist it around. You may not know my institute. We are a small institute, 25 people. It's a non-profit organization, primarily funded by National Institute of Health in US. Let's get on with it. My declarations is mainly that the butter on my bread comes from Medtronic. I have numerous patents also, but it's not really related to this work. So no need to use a lot of time on this. On the left side, we have the two expulsion or evacuation tests that has been presented. I call the other static or semi-static test, high-resolution manometry. And there are others as well, endoflip, ultrasonography, electromyography, and so on. So, what are the downsides? Now you have heard more about the advantages, though I did hear some critical points from some of the speakers. In my view, and in short terms, I mean, balloon expulsion technology, it's an extremely simple test. There are no sensors at all. We just measure the time or duration, but we don't even know if we do that correct, if the patient needs privacy. One size fits all. So if you study a 40-kilo woman or a 200-kilo man, you use the same balloon size. That must give you some kind of variation. And people use different catheters. And probably the different stiffness of catheters, I mean, give more variation in your data set. For defecography, by itself, it does not measure pressure. Adil just presented, yeah, we can combine it with manometry. Sure, we can combine everything. But it does not measure pressure. Pressure and force are important. It's a liquid, and if you really want to compare it with the Bristol stool form scale, it can only be from the description type 7, because that's the only one that's liquid, no blobs, no nothing. Measurements are very time-consuming. They are subjective, so when you measure diameters, especially the anal rectal angle, you can almost get whatever result that you want. And there's a capital cost too. For high-resolution manometry, the catheter is in a fixed position. It's not a defecatory test, but they try to simulate defecation. So it's not a simulated feces, but they simulate defecation by doing the push procedure. But the main point, and I'll get back to that, pressure measurements are radial. So they use circumferential electrodes that gives you a radial pressure measurement. I come back to that. And some measures, some pressure measures are way off. Look at what has been published and said about the RAPG, the rectoanal pressure gradient. Negative values are accepted where they clearly need to be positive when you do a push procedure. And people seems more or less to accept that fact and just say, okay, this is the normality for this wrong measure. Again, capital investment, you need to buy this expensive machine and expensive catheters. And finally, endoflip. As you know, I invented it. I'm not in favor of it for anal measurements. Again, it's a catheter, it's in a fixed position. You only get one pressure measurement, you get a lot of diameters, but it never really made a breakthrough, and I don't think it will in anal rectal physiology. So currently there's no approved test that kind of combines all these things with the patient in the correct position and so on. So what do we want to measure? The previous speakers have already been through this. This is not rocket science anymore, but I do want to point out about pressures, or rather we should talk about forces. And we have a very simple force equilibrium model here. So if we have a tube and flow in this tube, and that is what we are talking about, it's a transport process. So you would have a pushing force up here, and you would have a resistive force down here. And that will create some shear forces here, or frictional forces. So this goes in this direction, in the direction of the trajectory. But what does high-resolution manometry measure? It measures pressure in this direction here. And that explains a lot of the funny results we see. There's a very simple principle, because imagine a door, a sliding door. If it's open, there would be a flow through. So if we stand on this side of the door, let's say we stand inside rectum, and we open the door, it will flush out. There'll probably be a pressure and it will flush outside. If we now push extremely hard here, we have two elephants pushing from both sides. That will create an extremely high pressure. There'll be no flow. Easy to imagine. What if the two elephants doesn't push? We just close the door very lightly. Pressure very low, no flow. So there is no linear relationship whatsoever between a radial measured pressure and flow. But there will be a relationship between an axial pressure. So we want to measure axial pressure, which is my key point here. So again, these technologies, they have done a lot of good. Let's not throw them into the grave yet, or some of them into the grave, but let's take the best things from them. We learned a lot. So let's take the pressure recordings from high-resolution manometry. Let's take the diameter measurements from endoflip. Let's take the measurements of diameters and anal rectal angle from defecography, and of course balloon expulsion, and put it into one test that will do it all and in an electronic way. So these are some of the first prototypes of this device we call Figobionics. It's 10 centimeter long, 10 or 12 millimeter diameter, pressure sensors at the two ends because we measure the axial pressure. So it would flow in this direction. It also contains what we call MPUs, motion processor units. An MPU contains a three-dimensional gyroscope, accelerometer, and magnetometer. Just like in the cell phones, it always knows in which direction it's pointing. And if we have such a device in both ends, in this end and in this end, we can measure in three-dimensional space the orientation. And if you have that from both ends, you can use rather complex algorithms. You can compute the bending of the device. So when the device straddles the anal rectum, is being expelled, that change in bending angle is a reflection of the anal rectal angle. But it's measured electronically. We don't need to measure on defecography images. This is the newer version. You see the graphical user interface here. This is the 10 centimeter long balloon. This is the wireless transmitter. So this is completely wireless system. It has the impedance electrodes here, in addition to what I showed you up here. That's for the endoflip measurements. And let me show you in the next one if the videos will work. So here I move it around. You see in real time, when I do these movements or rotations, it shows this directly on the screen. You know if it sits in rectum, you know if it sits in anal rectum, and so on. And what about if we bend it? Here you see exactly how it bends, and you get the measurement. Here you can just read the value directly from that one. So let's go back a couple of years to the first device I showed and look at pressure recordings. So this is recordings. These are three phenotypes, totally normal phenotypes. This person take 2 attempts or abdominal contractions to defecate it. This one 3 and this one 6. It's all normal. What I really want to show here is that if you have the front pressure and the rear pressure, you can look at the difference. This is the rectoanal pressure gradient. We called it delta pressure at that time, but that doesn't matter. But if you plot the front pressure as function of the rear pressure, we also call that preload afterload plots, you would see these curves here where it moves up and down, and then the front pressure, the anal sphincter relaxes, and it kind of go below this line. If you're above the line, you cannot defecate. You cannot defecate against the pressure gradient. You actually have to go well below this line before it's expelled, and that is because of frictional force. So this guy have 6 attempts, slowly it goes out. In this case, it just took like 25 seconds, 6 contractions, and out it is. All normal. But there should be an example here. This one always takes a little while before it shifts, so give it a couple of seconds. These are phenotypes from obstructed defecators. It's a small study, 37 patients, and we looked at the same. These, the pressures here as function of time, and then again this diagram. We identified 6 subtypes. I show 4 of them here. This one, low amplitude contractions at all times above this line of unity. There's no way this person can defecate. You would even ask, is he even attempting to do it? Yes, it was. This one, very irregular patterns that goes in all directions with paradoxical contraction. Here a guy who tries for 2 minutes, even though he does seem to work down there, it never resulted in evacuation. And the last one here, with who can do it, but there's a paradoxical contraction here, but he does evacuate the device. So there's a lot of information in this very simple diagram that can inform us about normality and obstructed defecation. I have data also on fecal incontinence. This is a short talk, but there's a talk later on, and I'll go into that. So this is the graphical user interface. So we have the color contour up here, the heat map of the diameters, the pressures down here, the anorectal angle, and the orientation of the front and of the rear. And this is a three-dimensional diagram. So this is what it would look like on the screen. And here it's explained. This is after we filled fluid into the balloon. We don't use 50 milliliter. It doesn't make sense. We go until the urge to defecate level. So that means we also know the volume when they get urge or have first sensation. So the balloon is filled. We have left the room. We tell the patient, defecate when you're ready. And apparently it starts here. This is a one contraction thing. You may notice that the anorectal angle increases. It becomes straighter, about 15 degrees. And you will be able to see on this one here, it's on the way out because that's where the blue line is. But we can see that in a real-time view. So this is from a patient with constipation. So if you follow this line here, that it moves along the time axis, this is what you see here. So now it's totally horizontal. It's way up in rectum. So it's horizontal in this patient. Low amplitude contractions, but he does push it somewhat down towards the anal canal, but many attempts without production, then a paradoxical contraction, and eventually this patient would defecate it. But there's a lot of criteria here. This is, for me, a clearly pathological defecation pattern if you compare to the normal ones I showed earlier. There's a lot of information on this one. Maybe you want to start to look at this one because we have just made a new embodiment where we have a video camera at the tip. The video camera gives us anatomical information. This is during a push procedure. So you look from the rectum down towards the anal canal. Here you can see it opens up, so you actually see the black here is the outside. And continue to push, open the anal sphincter more and more. Look at how beautiful the irregularity is. So if we had to repair this thing surgically and endoscopically, this could guide us. Now we do a squeeze, and you see the anal canal closes completely, and it rolls towards the video camera. So it's just some fun because we like to continue to innovate. But to finish this talk, these are the most important results. I do give a talk later because a lot of this I have not really documented in this talk, but very importantly, because we have so many things we measure simultaneously, it's an integrated test, we can develop new metrics. We know the anorectal angle change when the pressure changes, when the diameter changes, and so on. We do have measures of the rectoanal pressure gradient that makes sense. It's positive when it's supposed to be positive, and negative when it's supposed to be negative. It fits fairly well, the duration with balloon expulsion. When we measure the angle, it fits very well. It's very well in agreement with the anterior anorectal angle. We have proven, and I will show data later, that it is in the range of type 3 to 4. But more importantly, clinically, there's a closer correlation to symptoms in FI, LAS, and OD patients. And we have shown that in 3 studies. It was clearly better correlated than high-resolution manometry and balloon expulsion. And for biofeedback monitoring, our parameters could predict the outcome. We've also been able to measure perineal descent. So all this taken together kind of gives us an integrated test. If you want to play with it, we have it on display in the coffee room. So come and play with it. There's a talk later on where I go more into detail. And I would like interested parties also to come and discuss at 5 o'clock. If you have ideas for application, if you're looking for having collaborators on application for funding and so on, National Institute of Health has treated us really, really well on this device, seem to like it a lot. And of course, at the end here, thanks to teams, collaborators, and sponsors so far. Thanks a lot.
I think, what do you think, Mark? Shall we break into coffee time by a couple of minutes or not?
It's fine. We can have a short round of questions. I don't know if some of the faculty would like to come up onto the front desk, because then you can use the speakers that are there and I don't have to wander between you. So if I could ask for Henriette, Mark and Adil and Mr. BET himself to take the stand. I don't know if you want to kick off with a comment or a question, Alison?
Maybe a comment. A few of the speakers mentioned combining these methodologies, and that's more practical in some situations than others. Maybe if you could comment on...
Okay, not enough seats. I get it.
That was the problem.
Here's a speaker.
What about the combination of different techniques? Obviously, in Mark Scott's lab, perhaps you do have the opportunity to do 3 at once. What do we think about a combination rather than just these tests in isolation?
We have the opportunity. We have the opportunity to do it, and we're doing it, I have to say, as part of a major research project. Our index test, as Adil said before, we favour defecography because it provides visual estimation of any anatomical or functional abnormalities. So in our hands, yes, there perhaps is some contributory information that you can certainly get from manometry, say, looking at reduced expulsive force. But an expulsion test, I get the pros, and I have to say that I was asked once, I gave a lecture to, it was the World Gastro Organization, and it was a similar sort of lecture, and I was in essence selling the pros of defecography, and one of the audience members said, that's all well and good, but we don't have access to radiology. So in those instances, of course, a more simple office-based test, of course, would be favourable. That's our experience.
Oh, can I ask a question? Sorry, Alison. It's Emma at the back somewhere. Great talks, everyone, as always. But I'm interested why we continue to have these sessions where we discuss a number of imperfect tests. Why don't we all just plug for the perfect one, which would be seated MR defecography? Why don't we just say that we're going to do that? Because I think that, to be honest, Mark, you know that I loved fluoroscopy when we did it together, but I think it's inadequate. I think that supine MR is inadequate. I think manometry is inadequate. I think that the Foley catheter and the balloon expulsion is inadequate. Why don't we just, as a group, start doing what is going to work?
In one of my standard talks, Emma, you will well know that it says there's a slide title that says, on my Christmas wish list would be if I had the perfect test. So obviously I agree with you, but I'll let others have their word as well.
As always, Emma, you're completely right, but there are sitting MRIs in Switzerland, and the waiting times are pretty long. Patients wait 6 months, even longer?
No, less than that, but...
No, you get in a month's time.
It depends on the place. So in Basel, where I come from, it's 6 months at the moment, so I might have to refer to Zurich.
Well, is there anywhere in Basel? But
there is one in Basel.
I will send them all to Altstetten, but just for the record, they are not infrequently poorly done. The quality is not fantastic, and there is disagreement between tests. So it's not the perfect test, and I speak as someone who does that reasonably regularly. I don't, Andreas, you...
I agree, I do quite often, and the Tesla is low, but we
we'll have the next one. We are in contact with some Italians, and they gave us now a better machine, and I believe that would be the future. But the old machine was, we were a little bit
Disappointed, yeah.
Giuseppe to comment.
Yeah, I think that we have to go back and focus on consistency, on fecal consistency. So if we do only defecography, then we will never know what happened when there is a solid stool. And, you know, most of our patients would have a type 1 or 2 Bristol stool scale. So if you change the fecal consistency, I think that we really need to have double tests for this reason. And, it's not standardized balloon expulsion test. And, we don't know if it's variable among different ages. There is a number of variables. But still, I think that we need to know something more about the influence of fecal consistency on evacuation. And without coupling at least 2 tests would be difficult. Because I think that you cannot, put, I think you have a standardized gel or mixture to do, what's happened when it's hard pellet stools?
Well, it matters. And we just published a study with Figobionics where we made the core of it stiffer. And clearly it was more difficult to evacuate the more stiffer probe. So it does matter.
Can I ask?
Sorry, I was just going to say, I mean, that was the basis of the original balloon expulsion test, a paper by Preston and Lennon Jones, who looked at expulsion of different types of marbles and balloons from the rectum. And obviously, the smaller and more dense the object, the harder it was to evacuate. So where it was all born from.
Can I ask the panel, these are all imperfect tests because they all test different things. Should we approach this with, if I'm asking the clinical question, should this patient go to a pelvic floor physiotherapist, I do anorectal manometry. If I'm wondering, should this patient be seeing a pelvic floor surgeon, I do defecography, rather than having one test that does it all.
I agree with that.
Well, I mean, coming in as a surgeon on the discussion here, but this is a problem that runs through the whole of the discussion this afternoon. And that ultimately, in the absence of any perfect test, there is no gold standard for this. The only gold standard you have is a response to therapy. And so, coming from a surgeon's angle, if I had a test that perfectly 100% predicts that if I repair a rectocele, that patient is relieved of their symptoms, that would be the gold standard. And the same could be said of all manner of different interventions in this area. But I mean, and the other general point I will make is one that's a statistical one. And that is that the whole of this area is confounded by the problem of looking at the differences between positive and negative predictive values of tests and likelihood ratios. So we've seen all the people who have presented here. They're 2 totally different things. And one relates to how you sequence something in a system to increase its value, positive or negative predictive value, but that does not tell you the likelihood ratio of actually having a diagnosis. Not that we can do it anyway because we don't have a gold standard to compare it to. So it's a very difficult field that doesn't have an answer at the moment, nor will we find one. But your point is well taken. And I think, Adil alluded to this. Patients who come to me because they have high degrees of prolapse. They're sent to me, so I'm a surgeon, and so defecography is a very useful test for me because it has a very high yield and therefore a very high positive predictive value of moving forwards. But the same would not be true if I was a gastroenterologist, I'm sure. So, this is we will not have resolution to this anytime.
And there's also that pragmatic view that Gregor Limburg put forward, as I put in one of my slides. We are dictated by resources as well, as I gave in one of the previous answers. It's fine for most of us in tertiary centres. We probably do have access to most of the tests, but many, many other jobbing clinicians don't. Emma, as you've said, the ideal, perfect test may be upright MR defecography. How many centres are going to have regular access to that? It's resources.
And the thing that no one's mentioned is clinically examining the patient, which is the other point.
Well,
I mean,
interestingly, I got a text from Natalia as just finished the talk saying exactly that.
You know, I mean, my use of all these tests is guided by examining the patient in part. I mean, you know, if they've got an obvious, if you do a POP-Q score and they've got a, you know, stage 3 rectocele, they've got a stage 3 rectocele.
Well, I think that, you know, we've had a fantastic run through of all the various options available. Tomorrow, the title of the session is Bringing It All Together. And I'm sure some of these topics will be warmed up again and considered perhaps more in clinical context rather than the rather kind of the technical run through that we've had today. So let me bring this session to a close. Let me invite you to go upstairs and get a coffee. And of course, in conclusion, today, there'll be 2 excellent symposia. One will, in a sense, continue in some extent the discussion that we've just had. Hans will be presenting more detail from the studies that he's done using this fascinating new technology, fecal bionics, which may be the perfect test, but hasn't yet been subjected to those trials. And secondly, Giuseppe Santoro will show us again some more of these fantastic images of the pelvic floor that he obtains using 3D ultrasound, perhaps not just static ones, perhaps also in movement, because you can use it as a screening test in the same way that we do use MR defecography in some circumstances. So that will be taking place in Sala Balint, which is where the large projector is. And for the rest of you, Atmo Biosciences will be presenting their fascinating work using the breath test capsule or gas sensing capsule, which gives unique insight into the digestive processes which are otherwise well hidden from us all. Thank you very much, and I'll expect you back at 4. Yeah.